Yeah.
Waiting approach. Yes.
Yes, you have to give parents very nice drops of antidepressive treatment. Antidepressant.
Yeah.
And then they will be waiting.
Do you have any case with melaleukia?
No.
Let me include one.
So we'll start in a couple of minutes here.
Okay.
People are joining. That's someone from Doha. Welcome. Kashmir, Beirut.
Hello from the Philippines.
Yeah.
Liverpool, Brazil.
Yeah, it's late in Australia, I guess, at least on the east.
Australia is in middle of the night? No.
It's in Australia. In Sydney, it's 11.
Sydney is 11.
Yeah. Yeah.
Morocco. They can already see us.
Yeah.
Yeah. They can hear us.
Hear us, yes.
Yeah. Hello, everybody. Emilio, say hello to everybody.
Hello, guys. Wait, I'm still preparing something for you.
You are unprepared, Emilio.
No, I'm just trying to respond to the first comment that already came.
Yes. Yeah.
Yes.
Antonella, Bacio. 11 p.m. Australia. Yeah, Edward.
Yeah.
Latvia, Raimonds.
Raimonds, where is Raimonds?
He's live. He's online.
Yeah.
Watching us. We're listening.
Steve. Hi, Steve from Springfield. Yes. Great that you're here. How is everything in the States?
All right. Okay, we'll start this. Hi and welcome to our episode 8 of our Dermline on the Spot Dermoscopy series. My name is Torsten Trotzenberg. I'm the co-founder and head of product design at Regen. That's ever since we developed the first polarized dermatoscope 20 years ago. Our patented polarization technology combined with our curated color spectrum is what gives you that great view into the skin with your Dermline. Today we have something really special. We just don't have one of the most famous, most published dermoscopists or dermoscopy experts here. We have two. These are not only great at what they do, they're also among the best speakers anywhere. And definitely the best teachers in dermoscopy. But just like the rest of us, they are not perfect. So today they'll talk about their worst disasters in dermoscopy. So both really don't need an introduction. We have Geppi Argenziano here. He's the head of the dermatology unit in Naples, Italy. Hi, Geppi.
Torsten, hello.
Good to have you. And we have Aimilios Lallas here with us today. Superstar. If you don't know Aimilios, maybe you haven't done dermoscopy. He's from Thessaloniki, Greece, joining us today. And we're all in a very good mood. And this should be a fun episode. Welcome, Aimilios.
Thank you, Torsten. Hello to everybody.
Yeah, thanks for being here, guys. I'm so grateful to both of you and all those who have been supporting our efforts to expand dermoscopy knowledge. We have a common mission to spread that knowledge worldwide. And it's amazing to see every day how our products are being used by dermatologists every day, and how they've really revolutionized the way we do dermoscopy by putting that technology in everyone's pocket. Just to a little housekeeping here, if you haven't seen previous episodes, we are going to do a Q&A and we do this via text. You have a Q&A button on your screen there. You can ask questions, and we will try to get to everyone's questions during this hour. Unfortunately, I'll already apologize, we can't get to everyone, but we will try our very best. This time we won't have a poll feature, so we won't be asking you questions necessarily, or not, at least not using the poll feature. But we will have a very interactive style between Geppi and Aimilios. So this should be very fun. I think the idea is they'll comment on each other's cases. So anyway, without further ado, let's get started. You guys are on the spot. So whoever wants to start, I think Geppi.
Well, I don't know. We even didn't prepare this, you know. So first of all, hi to everybody. Can everybody pronounce correctly the difficult name of Torsten? Torsten Trotzenberg. My God, this is for an Italian. This is so difficult.
It's difficult. It's not my fault, Geppi.
Emilio, you are the boss. Who is going to start?
I am the boss. No way. No way. Well, I already started to checking the comments. First, I would like to tell you that if you want to send something, please use the Q&A and not the chat.
Yes.
So that we'll be able to, maybe we will be able to see an answer. So I would say that let me start, because I was able to, it's strange. We start with the questions first. So we already received a couple of questions. And I was able to prepare one slide that addresses the two first that arrived. And the first one was that on melanonychia striata in children. And the comment was that parents can never be satisfied with the weight approach. So what should we do? Okay. Let me show you something.
Show us.
Here we go. So, do you like this nail band, Geppi?
I still don't see it.
You don't see it?
No. I still see my most frequent mistakes.
Mm-hmm.
You also, Torsten?
Yes.
Okay.
There we go.
Here we go. Okay. Well, yeah, of course, I don't like it because it's large and irregular.
So it has all the criteria of melanoma, doesn't it?
Of course. Fulfilling the criteria, morphologic criteria of melanoma.
Okay, so now there is an information that you don't have, and this is the information. Now?
Sharing your screen, really?
We still see the same picture.
But why does it happen? I cannot understand. Bring your shirt with the front. Now?
No.
You don't share the screen anymore.
You see problems.
Yes.
Okay.
Now
I'm trying.
Try again.
no problem. We see it.
Okay.
Great. Go ahead. Yes, this is a 7-year-old girl.
Exactly. So now, do you change your assessment?
Of course, I know mathematically that this is a congenital nevus.
So should we follow up?
Of course, we follow up.
Why?
Well, we follow up for the reason that in medicine there is no 100%. So still there is a 0.00001% chance that this is a melanoma. Therefore, I have to follow up. What I expect to find in the follow-up? What do you expect to find in the follow-up?
Well, I don't agree that we need to follow up.
But this is the point is that if we follow, we make it clear also with parents what it's expected to see, it's actually happening, meaning that the lesion slowly is going to disappear.
Yeah. So the problem is the parents, not the real need.
Of course, the problem is the parents.
So the point is that congenital nevi, because this is a congenital nevus, the point is that congenital nevi in general very often acquire characteristics which theoretically are melanoma characteristics. So they look like melanoma, they don't look like nevi. And this is the case with congenital nevi of many sites, including the nails. So the point is that precisely the same morphology which would lead me to the conclusion that this is a melanoma, precisely the same morphology leads me to the conclusion that this is a congenital nevus since the age is 7. And the point is that, especially in nail melanoma, we know that if melanoma develops on the matrix of the nail, then it's almost always de novo, so it never develops on a pre-existing nevus. That's why I'm saying that theoretically, there is no need to monitor the congenital.
An interesting question, exactly pointing this point. Is acral melanoma more frequent to be de novo or associated with an acral congenital nevus?
I have the answer also to this one.
Yes.
Yeah, so I was able to add it. So, in general, for melanoma, which are the percentages, de novo and nevus associated, more or less? In general, 70-30, correct?
Correct.
5-25, 75 de novo, 25 nevus associated, okay? Now, for acral melanoma, which are the numbers? Let's take a look at this study of Edu Nagore a few years ago. Check the last the last row of the table on the right. In how many melanomas, acral melanomas, they found remnants of pre-existing nevus? The percentage was 8%.
Mm.
So not 25, as it is for melanoma in general, but 8, which means that even a smaller proportion of acral melanomas are associated with a nevus. And for nail melanoma, the percentage theoretically is 0. So all nail melanomas develop de novo. Therefore, I would say that monitoring congenital nevi of the nail plate, in fact, is not something necessary, but I agree, we do it mainly for the parents. And this is a problem sometimes because, as the colleagues say, the parents are never satisfied with a wait-and-see approach. How do you deal with the parents' problem?
Well, in a paternalistic way. We have to be, all of us doctors, we have to be very charismatic with them and trying to convince them that we are on the same boat. And they have to follow our suggestions. No, but it's true that I mean, once we understand how to relax by ourselves, then we will be able to make the parents relaxed as well. You know what I mean? If we are scared, definitely also the parents will be scared. So once we know that basically congenital nevi, large bands of the nail unit of children are just congenital nevi, and the chance that they are melanoma is almost 0, then we are really able to relax ourselves and the parents.
Exactly.
Anyway, let's go to your cases, Emilio.
Okay, first, do you agree that with this statement?
Yes, I agree 100%. To avoid mistakes is...
If you don't want to make mistakes, just go home.
Yes. Go to a very nice holiday island and enjoy yourself.
Exactly. This is the only safe way. Okay, let's take a look at a patient of mine. Okay, so as you can see, this is a patient with quite a lot of sun damage. There is a scar here from a previous squamous cell carcinoma which was excised. In this visit, we found this lesion on his cheek. You can see it in the middle of the slide, I guess. Okay, and I will show you directly visit 2. This is the same area after the treatment we did in visit 1. The treatment was cryotherapy. We assessed it as an actinic keratosis, and we decided to do cryotherapy. And I guess that you agree that we did a really good job. Do you agree?
Beautiful.
Beautiful. Good. But definitely, since this is a patient with a lot of sun damage, we continue to monitor, obviously. Okay? And then the patient comes back again. So visit 1, visit 2. You can see here the close-up, how well the lesion responded to our cryotherapy. And now, visit 3. Okay? Mm-hmm. You can see an overview of the same area here. You can see that the treatment area is still okay, but probably you can see something additional in this image on the top.
Yeah.
Okay. Good. Which was finally an invasive squamous cell carcinoma. So now let's go back to visit 2 and visit 1. Can you see?
In visit 2, there was already something.
It was already there.
Mm.
Okay, so here I can show you how beautifully we monitored the formation of a squamous cell carcinoma in a patient that theoretically we visited many times. So we had the chance more than once to do what we should do, but we didn't. Which was the problem here? The problem is that we treated only one AK and we didn't take care of the field of the patient. We didn't do any kind of field treatment. So finally, we monitored something which was expected. What? A formation of a squamous cell carcinoma in a cancerized field.
Yeah.
Do you like my mistake?
No, definitely. I like this this case. I like it. Yeah. Yeah.
Okay, your turn.
My turn. Okay. So this is a mistake, which is let's grade our mistakes from 1 to 3. 1 is light mistake, 2 is moderate, and 3 is severe mistake.
In terms of
say that this is moderate.
In terms of consequences or in terms of if you could avoid it?
In terms of consequences of for the life expectation of our patients. Moderate. Okay. Yeah. Good. Perfect. Okay, it's my turn. Okay. So I'm going to show you my first case. My first case is this one. This is a 45-year-old lady, lots of nevi. There is especially one lesion that you can see here with the harrow, which is at the baseline visit looking like this. Emilio, should we excise it or can we do follow-up?
Of course.
Follow-up, okay. This is after 6 months. Should you excise it? No, come on. This is after 1 year. Should we excise it? No. This is after 18 months. Should we excise it?
How old was the patient?
45.
45. You didn't help me a lot.
Nah.
Well, maybe. I'm not sure. Maybe yes.
Well, we decided not to excise it because we wanted to arrive to this morphology. Look how beautiful is this morphology. It's my heart beating for demoscopy and for you two guys.
You're so romantic.
So anyway, 2 years, 24 months, we then excised this lesion, which revealed to be a melanoma in situ. Do you think, Emilio, that this was a melanoma in situ already 2 years before?
Yes, but I won't tell it to you.
No, it was definitely a melanoma in situ already 2 years ago, but nothing bad happened. You know what I mean? So we understood that there is a form of melanoma, which is the Neapolitan melanoma, very lazy, no? I'm joking, but a very slow growing melanoma. So we have plenty of time to make a diagnosis. A flat reticular melanoma is usually growing very slowly. But, you know, now we come to the mistake. Okay, this is another patient. He's 50, he's a man. His skin is looking like this. Can you imagine? Okay. Mm-hmm. I started to follow up this guy in 2008. Okay. Why? Because we removed this melanoma in situ. No follow-up immediately. Okay. Va bene? Then we, of course, we followed him up every 6 months forever. And he was a very precise guy, coming every 6 months. Okay. And now we come to 2016, 8 years later. And this is a bunch of his nevi in 2016. Emilio, is there something you want to remove now?
Everything. Everything. This angioma there.
Yes, this is a nice combination. A melanocytic lesion and an hemangioma. Okay, so we know that these are all ugly nevi, but since they are flat and reticular, we are on the safe side doing follow-up. Okay, so we continued follow-up. But what happened?
They are a nice company.
Yes, but it happened something which was not foreseeable. We cannot expect. He broke his leg. So he was not able to show up in his regular follow-up every 6 months, but he came 2 years later. Mm-hmm. So he skipped 2 years of follow-up. And we found one melanoma, a brand new one. We didn't have any picture before. Okay, 0.5 nevus associated. And we found the second melanoma. This is a bad one. But can you recognize the angioma?
Yes.
Yes. This is a 1.1 millimeter thick melanoma. Can you imagine? Is this one top right?
Wow. Wow.
Okay. So, did we make a mistake? Maybe not.
No.
Did the patient make a mistake? No. It was the fate. He broke his leg and he was able not to come anymore for 2 years. So nothing happened in 10 years, but then in 2 years, a very slow-growing melanoma developed into a more aggressive one. Yeah. Okay, so what we learned by this patient is that we need everything works with this patient with multiple nevi if he comes for follow-up. If there is something going on and he doesn't show up for follow-up, then it could be a disaster. Anyway, we found another melanoma in 2019. So this guy is not coming every 6 months anymore. He's coming every 4 months. Yeah.
That's why in these high-risk patients, we need to apply the rules. So we need to continue with monitoring, even if sometimes, I mean, you feel like, come on, I'm visiting this patient for 10 years, every 6 months, and nothing happens. And then the patient says, doctor, can we do it less frequently? Can we do it once every 2 years? And you need to say, no, we need to follow the plan, because the plan was based on mistakes, not on mistakes, but on situations like this.
Yeah, I agree 100%. Okay, Emilio, that's your turn now. How we score this mistake?
No. In terms of consequences, we score it with number 3.
Number 3, severe.
Yes, but in terms of maybe you could avoid it, I mean, you didn't do anything. And you didn't do anything wrong. I mean, what could you do?
I know.
Yeah.
So severe. Okay.
Okay. So,
So,
but again, I have this problem with, I don't know why it happens. No, sharing is paused. Why? I don't know.
maybe you have to go out and go in. Yeah, now it should be okay. Yes.
Okay, good. So I remain in the same, let's say, more or less category, patients without hairs, because obviously this is my favorite category of patients. And with, let's say, field cancerization. Again, history of squamous cell carcinoma. You can see, I guess, the graft in the middle of the head, okay? And now the patient appears with these, let's say, with these lesions. But let's focus our attention on the largest one, close up, okay? And a strange dermoscopy. Don't you agree?
I agree.
Too many vessels, linear, the vast majority of them. Okay, overall, what would you think as the highest probability?
Well, there are two options. One option is that this is a epithelial cancer, of course, I mean, in situ or invasive, or
Could also be, if it is a squamous cell, it could be poorly differentiated squamous cell.
sì, poorly. But there is a chance that this could be erosive.
No, stop. I know what you're going to say. Stop. Don't do it. Okay, the point is that this lesion was biopsied, and then the result was nothing. You know, inflammation, unspecific inflammation, and so on. Which at that time when it happened to us, it was so strange. I mean, the interpretation of this report was that a mistake happened, because this cannot be nothing. This is something. Maybe VCC or an SCC, I don't know, or what else it could be, but for sure this is something, okay? And then the patient comes back in order to check what's going on, and this is the situation. Till we are not able to understand what is going on, then we remove the crusts a little bit, and this is the situation. So again, I mean, we guess that these foci are suspicious for squamous cell carcinoma in a cancerized field anyhow, because the field was cancerized. And finally, in the next visit, everything came to light, because we were not so much familiar a few years ago with this entity. You agree, Geppi? This is something that 5-6 years ago did not cross our mind so much.
I agree.
And as you said from the beginning, here it's clear cut. This is an entity which is called erosive pustular dermatosis of the scalp, which is an inflammatory immunologic reaction typically developing in patients with history of non-melanoma skin cancer treated with field treatments or even with surgery. And here, which is the treatment that we need to apply?
Steroids.
Steroids. You apply steroids, and after this is dermoscopy, by the way. See the pustules, how evident they are. And yeah, after 1 week of dermoscopy of topical steroids, already the situation is much better. But let me show you an even worse case of the same entity. Look at this. Can you see the margins of the graft? So this patient had been biopsied 5-6 times by surgeons. Finally, they were not able to understand what's going on, and they decided to do a huge excision and replacement with graft. So you can see the size of the graft. And look how impressive it is that the disease developed on the graft. So it's quite impressive.
Wow.
And again, after, this is the first time that we saw him. Of course, the diagnosis was easy at this point. And again, after 1 week of steroids, look immediately how the clinical image changes a lot. But let me show you something else concerning the same entity. So usually we apply a little bit of steroids and everything is easy. You agree?
Yeah.
But sometimes I would like to share with you this patient of mine, which really was a big problem,
Yes, because this is a thick ulceration.
No, this is not even an ulceration. Yeah, this is even more than an ulceration. I will show you. So the problem here was active disease. We give steroids, responding, but then when we stopped steroids, immediately recurring. And again steroids, and again recurring, and again steroids. And which is the result after so long use of steroids? Atrophy.
Yeah.
So the skin is practically disappearing. So again, here you can see that the disease is quite active. We administer steroids. In fact, look at the periphery, look at the two images. So the disease responds. But in the center, what you can see now, you know what it is? This white color in the center. You know what it is?
Oh, the bone.
So the skin was completely destroyed. And therefore here there is a big problem. Here there is a risk of infection, and obviously this cannot remain like this. Here we need to do an operation in order to protect the bone. So now the question is, do you have any idea on how we could manage cases that that recur continuously when you stop the steroids?
Well, no, because this never happened to me until now.
Yeah. So what I thought, in the literature there are very few things, but what we did now in a couple of 3-4 patients that were recurring again and again is to use systemic retinoids.
It's a good option. Yeah.
This is an example that I will show you. Baseline again, after topical steroids, responding. And then here, in this image, this is the situation without steroids anymore, but with systemic retinoids. So the disease is still there, but at least it's not progressing. So we are able to keep them in a stable, at least, situation without the need for continuous use of steroids.
Yeah, this is a good option because then you have the both effects of controlling the pustular dermatosis, but also to treat a little bit the field cancerization, because we use a lot of retinoids in these difficult patients. Yeah.
But this guy with a huge graft was really impressive. I mean, yeah, really impressive. Okay, go.
Okay, it's my turn. Va bene. I go. Here we are. Okay, I'm speaking now about this colleague. She is 60 years of age, and she has a facial pigmented lesion since 20 years. Okay, Emilio? And the previous punch biopsy performed 10 years ago revealed a junctional nevus. You already know the story. So you don't know the patient, but you know the story. It's very repetitive. So this is the patient, and this is the lesion. Okay? So a previous biopsy performed 10 years ago revealed the junctional nevus. So this is the clinical, this is the dermoscopy. Do you see clear-cut melanoma-specific criteria, Emilio?
Well, maybe in this image, I would say not clear-cut. No, clear-cut, no.
Not clear-cut, exactly.
Clear-cut,
so
no.
The point is that the previous colleagues decided not to perform any other biopsy. Why? Because they thought this is a seborrheic keratosis. Because why they thought it could be a non-melanoma lesion? Because there are no melanoma-specific criteria clearly evident. But now we both know that on the face, melanoma is a big problem. It's a big problem because even in a large case like this, it could be possible that melanoma-specific criteria are not visible. So we have to inverse, to make an inversion. We have to use the inverse approach. So meaning that we first have to search for benign features. And if we don't find them, then we have to be very suspicious. Do you see clear-cut benign features here, Emilio?
No, but
Not really.
but we also have to explain that, I mean, the word clear-cut is important. So we are speaking about features which are obvious and they predominate in the lesion.
They are prevalent. Exactly.
Prevalent. Exactly. Yeah. So no, I don't see anything very prevalent because one that exists is not enough.
Exactly. So that's the point, you know. So here there are two things which are making me very suspicious. First, the previous pathology speaking about the junctional nevus. This is a very old story, you know. Sometimes when you make a partial biopsy of a melanoma of the face, the pathologist has no, let's say, definite criteria to say it's a melanoma. And then they say it's a junctional nevus. But we know that the morphology here is not compatible with a junctional nevus. A junctional nevus could be a very tiny lesion, a small lesion in a child, but definitely this large lesion cannot be a junctional nevus in a 60-year-old lady. Okay, so this is the first point. And the second point is that I don't see clear-cut benign features. That's why we decided to remove the lesion entirely. Okay, and this of course was a melanoma, invasive, by the way. Okay, so these are the 6 benign features we usually use to make clear that the lesion we are confronting on the face is benign. 3 are referring to pigmented decay, pigmented and non-pigmented decays, actinic keratosis like scales, white follicles, erythema, okay, or reticular vessels. And the other 3 are referring to solar lentigos, reticular lines, sharp demarcation, and classic seborrheic keratosis criteria. So when I see a lesion on the face, I usually do this always the same approach. I ask myself, do I see prevalent, clear-cut, benign features? And my answer here is yes. Do you agree, Emilio?
Of course.
Fingerprinting, reticular lines, sharp demarcation at the periphery, white follicles, okay? Another example, do I see clear-cut benign features here, prevalent? Yes, reticular lines, okay? Here, do you see clear-cut benign features, Emilio?
Beautiful white and white follicles.
White follicles, exactly. Exactly, so pigmented actinic keratosis. Emilio, do you see clear-cut benign features here, prevalent?
No.
Exactly, exactly. And the point is this, when you do this approach, when you use this approach and then you come to the conclusion, oh my God. When you come to the conclusion, well, I don't see clear-cut benign features. Just a moment. Okay. I don't see prevalent benign features. Then my index of suspicion is rising. And then I can ask myself, but do I see a little bit of gray color? Do I see a little bit of annular granular? Yes, I see it now. Okay. Do I see a little bit of asymmetric pigmented follicles? Yes, I see a little bit of them, you know? But if we concentrate first on the melanoma-specific criteria, we can miss a lot of these cases. Okay.
Because it's not easy. It's not easy to force your brain to think in the opposite way. We are so much used to look for criteria which suggest a diagnosis that it's not easy. You have to remember the rule and apply it, to force yourself to apply it.
Somebody wants to know the benign features. Maybe you can mention them again. The 6 benign features.
Yes.
Yeah. Yeah, the 6 benign features. Again, I give you the list. I give you the list. So scales, pigmented or non-pigmented, white follicles or rosettes. If you use a polarized light dermoscopy, you will see rosettes. If you use a regular light dermoscopy, then you will see white follicles. Erythema or reticular vessels, these three are found in actinic keratosis. And then reticular lines of fingerprints, sharp demarcation, and classic seborrheic keratosis criteria. These are found in solar lenticels. Good.
Okay.
Emilio, go ahead, go ahead.
I'll try, although I always
Oh, sorry, Torsten, are you keeping an eye on the questions? Because
Yeah, you want me to just ask them, just throw them in as they come in?
okay.
We had, I mean, the retinoids, we have some questions regarding those. I don't know if we want to.
Yeah, I saw them. So first, for protopic, which is a very reasonable thought, we are referring to erosive pustular dermatosis again. Protopic is a very reasonable thought in order to spare steroids. But unfortunately, according to the very, very few published evidence and to our experience, unfortunately, it does not seem to work to control adequately the disease after the removal of steroids. At least this is our experience. I repeat, we don't have large studies and robust data. Concerning the dosage of retinoids that we use, it is 25 milligram of neoticazone per day. This is the dosage that we use.
We do.
Okay. Now, one of my favorite cases, clinically, okay, and then close up. So you see already that there is a nodule and there is also a flat part. Okay, evident. Now, look at what a strange morphology dermatoscopically. So let's speak a little bit about it. In the nodular part, Geppi, I describe and you tell me if you disagree somewhere. In the nodular part, it is hypopigmented. There is pigmentation, but not much. The pigmentation does not help me. I see vessels, they are linear, they are short, they are a little bit ramified. They could be compatible with even with the coma vessels of a dermal nevus.
Are they sharp in focus?
They are not really sharp in focus. So I cannot exclude that this lesion is a dermal nevus. Of course, an alternative idea could be that these vessels correspond to the vessels of basal cell carcinoma. Although this brownish pigmentation of the nodular lesion is not so much compatible with basal cell carcinoma. And finally, I also see a white shiny streak, white shiny strand, which is not a good sign. It might be present in basal cell carcinoma or also in melanoma. Overall, morphologically, this lesion, I would say that I am between dermal nevus and basal cell carcinoma, most probably. But now, if it was alone, now together with the flat one, if I look at it by itself, I would say that it could be even in solar lentigo, or if not, a junctional nevus. Yeah, that's my differential for the flat part. Do you agree with what I said until now?
Well, yes, but I see that with this evaluation, you are very, very, very optimistic.
No, but this was a real discussion. So many people that examined this patient, many doctors, we did these ideas came. Okay, this could be a dermal nevus colliding with a solar lentigo. This could be a basal cell carcinoma colliding with solar lentigo, or a dermal nevus with a junctional nevus, and so on and so on. And of course, at that moment, before the excision of the lesion, I could not exclude any of them. All these possibilities could be the case. Okay? And then, of course, of course, there is also the possibility that this is not a collision of two lesions, but everything is one. And if everything is one, then the game changes completely, because the only lesion that can look like this, if we consider it as one lesion, everything, is melanoma. So the point is that, which was the mistake here, it was not a huge mistake, because of course we decided to excise the lesion, but we decided to excise it mainly with the first 4 differential diagnoses, so not as an urgent excision. And finally, the bad possibility came true. This was a melanoma with a nodular part and a flat part. It was not a dermal nevus with a melanoma. Everything was melanoma. And from this case, what I learned is that, of course, collision tumors exist. It's possible that you will find in your daily practice something strange. A dermal nevus colliding with a solar lendigo could be. A basal cell carcinoma colliding with, I don't know, with a junctional nevus could be. Collisions are frequent, but single tumors are much more frequent. So when you start thinking crazy things, when you start thinking about infrequent things, then at the same moment think that, okay, it could be, but the highest possibility is that everything corresponds to one disease. And if everything corresponds to one disease, then this can only be a melanoma.
Yeah.
Huh?
Yes, it's a nice case.
Question, somebody wants to know if there's regression in the flat part of the lesion? The last question.
There is regression, you mean in the lower part of the lesion? Okay, not evident for sure, but yeah, this could correspond to a small area of regression.
Okay.
The point is that, of course, now that we know that this is a melanoma, if you look at the nodular part of the melanoma, this is not what we usually see in the nodular part of the melanoma. So this lesion does not display clear-cut melanoma criteria. That's why you start doing these strange thoughts. Anyhow, in my view, the useful message here is this one. When you start doing crazy thoughts, then think about melanoma.
Yes, but this is something I learned a few years ago. First, when you see something you not fitting with a specific diagnosis, we have to keep simple. We don't have to start thinking about the most mysterious diseases. We have to understand that most often when we see something we don't understand what it is, it's just an unusual presentation of a common condition, of something we know. Okay, so it's extremely important to keep it simple.
Yeah. The patient, by the way, somebody's asking, was 35 years old, so quite young. Okay, go.
I go with my case. Here we are. Okay. Now, I like this one. This is a gentleman with a clear-cut, atypical lesion on the arm. Don't you think so, Emilio?
Sorry.
With a very, very ugly lesion, right? Very ugly. It could be what? It could be melanoma with extensive regression, right?
Yes.
Okay. This guy, by the way, was sent to us from the oncology department of another hospital, because 1 month before of our consultation, they excised a lymph node, a metastatic lymph node, which revealed to be a metastatic melanoma in the axilla, okay? And he comes from the surgery, not the oncology, for searching the primary melanoma that, of course, obviously we found on the arm. What was the problem here? The mistake. The mistake is that 5 years before the development of the lymph node metastasis, the same lesion was a lesion located exactly in the same area was excised, and a histopathologic diagnosis of dysplastic nevus was made. So what happened here? Probably that this was not a dysplastic nevus, this was a melanoma which was remaining there, because the lesion was, of course, there was no wide excision following the diagnosis of dysplastic nevus. Okay, so then the melanoma was recurring locally until it was able to give metastasis. Okay, so now this is the point. It's a mistake which was teaching me what? It was teaching me that we have to make sure when we get a diagnosis of dysplastic nevus from our pathologist, we have to make sure what is convenient to do. Should we perform anyhow wide excision always, or in selected cases? In my view, in selected cases, when I think that the lesion could be really a melanoma, it's better to do a wide excision. I give you another example on the same line. This lady comes with this recurrence. Can you see the scar, Emilio?
Yeah.
Yeah, and there is a little papule on one side of the scar. The lesion 2 years before was diagnosed as a junctional nevus with dysplastic features, so dysplastic nevus, okay? But of course, now this is a clear-cut melanoma. So this, again, was not a dysplastic nevus when it was excised 2 years ago, but it was already a melanoma, which is recurring because no wide excision was performed.
So which is the mistake?
The mistake here could be like this one here, okay? If I do a mistake like this, but because of the previous two cases, we didn't do a mistake, okay? This is a 64-year-old man. He comes with a clear-cut melanoma, don't you agree?
Of course.
Okay, we excise it, and the patient comes for follow-up. 1 year later, we realized that there is another atypical lesion under the scar of the previous melanoma, okay? But if you go back to the baseline examination, the lesion was already there. It was definitely, the lesion is changing quite a lot, right? Don't you think so, already clinically? And this is what we can see dermoscopically. It's an asymmetric lesion, not really shouting as a melanoma, right? But it's ugly enough to be excised, right? And then the pathology comes back as a dysplastic nevus, okay? And now here's the point. Should we leave it like that, or should we excise it, or re-excise it?
So
What do you think?
I think that we need to discuss a little bit about it, because also there are some questions if we should remove always a dysplastic nevus. So in my view,
No. But this is a much larger question. I'm speaking about a lesion that you removed because you thought it could be a melanoma, and then the pathology comes back as a dysplastic nevus.
Exactly. Right? Therefore, in fact, what we believe, what I believe and you believe for all these lesions that you showed, is that obviously they were melanomas which were, let's say, incorrectly classified histopathologically. But since we cannot start again the fight with the with those pathologists,
we have to decide what to do. Should I treat it as a melanoma or not? And this is depending on what we think, putting everything together. The clinical, the age of the patient, the history, the changes, eventual changes over follow-up, the morphology. And then by putting together, if I think that this could strongly be a melanoma, I re-excise. If I don't think that this could be really a melanoma, then I leave it there. You know?
Exactly. So the point is that we don't excise dysplastic nevi. We excise melanomas. The point is that we don't believe that this is a dysplastic nevus. We believe that this is a melanoma, and that's why we recommend excision. But if you go back to the, especially to the first case that you showed, the idea behind is that a dysplastic nevus, to our understanding, can only be present in young people with multiple ugly nevi. In the first case that Geppi showed, this was a solitary lesion developing. I mean, come on, look at the age, look at the overall skin of the patient. This is not a patient with multiple dysplastic nevi. This is a patient, an old patient with a solitary lesion. So it cannot be a nevus. It cannot be a dysplastic nevus. We believe that this is a melanoma, and that's why we should re-excise it. That's the exactly point. But this fight with the dysplastic, we should not start it again, because
no, it's not. We have to admit that this will never be solved. But when we get a diagnosis like this, we have to strongly ask ourselves, do I believe that this is just a nevus, benign, or I still think that this could be a melanoma based on my criteria?
Exactly.
Good.
Okay, let's... are you ready for a little bit of fun?
Yes, please.
No, let's share some new funny concepts that we developed recently, starting with this one. So, Geppi.
Yes.
Do you see the patient?
Hey, it looks like you.
No, he's a little bit older than me. He's 55 years old with this lesion on his scalp.
Okay.
How do you assess it?
It's a bluish lesion.
Yeah.
It's a blue nevus.
Blue nevus. So then, what should you do?
Nothing.
You ask the patient how long it's there, and the patient says that he doesn't know. It's there maybe 1-2 years, doesn't know.
Yeah. But we know that is, yeah.
But this is what you teach so many years to the people. You teach.
No, I don't teach this anymore.
Eh?
I don't teach this anymore.
That the diagnosis of blue nevus should always be confirmed by the history. So you should ask the patient, how long is it there on his scalp? Eh? So should we change? Should we cancel it?
Yes.
And replace it with this one, maybe?
Yes. Like a blue nevus is a blue nevus. Exactly.
Why we say so? We say so because this, I mean, come on, a blue lesion with homogeneous blue color cannot be a melanoma. It cannot be a melanoma because melanomas are not, I mean, do not display symmetric blue color. It could, however, be something else related to melanoma, not primary tumor, but something else. For example, take a look at this one clinically and dermoscopically. So the only thing that should cross your mind every time you examine a blue nevus, the only thing is to check if there is a possibility that it could be a melanoma metastasis, because melanoma metastasis might be perfectly identical to a blue nevus, homogeneous blue color and nothing else. So what should we do? We should first make a question, do you have a history of melanoma? And then check the surrounding skin to see if possibly there are more lesions like this one, because a metastasis is very rare to be solitary. Usually the metastasis will be more than one. For example, here there is already a second skin met. Okay, so a lesion looking like a blue nevus is a blue nevus. Just exclude melanoma metastasis. This is the message. Okay. Should I go on? Another common mistake. Okay. Clinically, what do you think, Geppi, about it? You like it or not?
Well, it could be a SEPK.
It could be a SEPK. Possibility number 1, possibility number 2.
Then Bowen.
Okay, possibility number 3.
Melanoma.
Yeah, lentiginous melanoma, why not?
Yes.
Okay, ready for demoscopy?
Yes.
Here you are.
Ah. It was looking like much more hyperkeratotic in the other picture. No, definitely this is very, very suspicious. Yeah.
Very, very suspicious. Okay, so you assess it as very, very suspicious. And then the patient says, doctor, don't look at it. I have it since 20 years.
I don't care.
You don't care.
No.
The problem is sometimes we care. Sometimes we listen too much. We listen too much. So, I mean, we should not care. The morphology here is highly suspicious. There is a lot of regression, many areas of regression, and there is nothing confirming that this is a seborrheic keratosis in regression. It could be, but there is nothing on the dermatoscopic image that makes me feel strong that this is a seborrheic keratosis in regression. Therefore, I should not care about what the patient says. Trust your eyes much more than your ears. So usually the eyes will give you much more reliable information than your ears, which is also something that a new theory that Geppi develops now, which is that history, you should take a careful history and then forget it. Okay, and the last one, and then I give it back to you to close. Another myth. So, please follow my cases. 1 year old, okay, clinical, dermoscopy. Questions, what is it? You see the options here.
You asked me?
Yes, you.
Ah, melanoma, clear cut. No, just kidding. A growing nevus.
It's dysplastic nevus, Sampus, Meltum,
No.
melanoma.
No.
A growing nevus. Eh?
Yes.
Why do you say so? Because you see peripheral globules.
Yes.
Okay. This was 1 year old. Now, 25 years old. Okay? Lesion. Clinical dermoscopy. The same question. Peripheral globules. 25 years old. What is it?
Growing nevus.
Growing nevus again. Okay. 40 years old. Clinical dermoscopy. Peripheral.
Yes.
What is it?
Growing nevus.
Growing nevus. Okay. 58 years old. Clinical dermoscopy. What is it?
A growing nevus.
Growing nevus. Exactly. That's the point. Let's finish with this story with the peripheral globules and the age. I mean, come on. A growing nevus, a growing nevus, a growing nevus, and a growing nevus. So, conclusion, a lesion with peripheral globules is a growing nevus. Yeah, I mean, I cannot do it in a simpler way.
No, that's exactly the right conclusion. Yeah, very beautiful. Very nice, very nice. No, we don't care. We don't care about peripheral globules, right? We don't care too much.
Okay, I mean, we care a little bit. I mean,
a little bit, yes.
Yeah. In extreme scenarios, maybe we care, like in a very, very advanced stage. It's so strange to see.
Let's say when the guy is 75, 80, 85, maybe it's a difference.
Yeah, then it's really strange to see a growing nevus.
Okay. Well, unfortunately, we have to finish with a catastrophic case. I'm very sorry. Okay, so this is written in Italian, but I can translate for you. This is a case of a colleague of mine, a dermatologist in my area, a very good one, who was seeing a little girl, 10 years old, with, he says, Geppi, I'm going to send you the images of a acral spitz nevus in a 10-year-old girl. I did a follow-up. So he was saying that this picture refers to August 2015, okay? And the other lesion is, sorry, let me see, January 2016, okay? So August 2015, this one, and January 2016, this one, okay? So the lesion is definitely growing, okay? I can understand why he was saying acral spitz nevus, because he said he visualizes this kind of very superficial black globules, which is very typical for spitz, in some way. Do you agree, Emilio?
Yeah.
Okay. But now, I mean, not very easy to say it's a spitz nevus. If I see the lesion now, I would say more on the side of a congenital nevus, right?
But well, also in the first image, I would, yeah.
Yeah.
I mean, I don't know how spitz acral
Yeah.
like, but this globe.
Okay. Exactly. Anyway, just to give you an idea, this is another case. This is another case which is pretty similar, same age, but another girl with a pretty similar congenital nevus. So you see this kind of heavily pigmented lesion following the furrows in some way, also like here. So the lesion is growing, but you know, the girl is 10, and you know, so we have to decide what to do, because the parents are very concerned.
Mm-hmm.
What is your suggestion, Emilio?
Why did you say that this is a sad story? Now you come on. I mean, the age is such a strong factor. For me, it's a really strong factor.
Yes.
So I want to believe that these are just congenital.
Yes.
Congenital nevi.
Yeah. Exactly. That's exactly what we said. Okay. We said don't worry. This is a congenital nevus. Of course, since the lesion is changing, we will follow up, but they disappeared, okay? And since 2016, now we go to November 2017, so it's almost 2 years, okay? 2 years later, I meet another colleague, a third one, at the Congress, and you know, just drinking a coffee at the bar, he was saying to me, you know, Geppi, that we saw a little girl that you saw also in Napoli. And by the way, we decided to excise this lesion, and this was a melanoma. And then I said, wait a minute. Melanoma in a small child that I saw already in Napoli, and I didn't excise it. Tell me more. So he said, okay. And then he sent me this email, and he says, ciao Geppi, this is the case I showed you at the Congress. This is a nevus present congenital, basically, since first year of age. This lesion was stable until the age of 10, and then it was changing. We excised it, and this was diagnosed as a melanoma 0.4 millimeter of thickness. And there are no histologic characteristics referring to nevus-associated melanoma. So this is a de novo. This is a de novo melanoma. Okay, this was diagnosed as a melanoma de novo. Okay, so then I replied to the colleague. I was saying, okay, when the lesion was excised, it was looking like this. So now of course, I understand why the third colleague decided to remove this lesion, because now it's really maybe too much, right? Okay. Anyway, don't you think this is a strange story? Huh? This is the pathology. 0.4 millimeter. Okay. Then I reply to the colleague, and I say, I thank you very much. But I mean, there are doubtful information here, doubtful things, meaning how can it be possible that a melanoma starts basically congenital since the first year of age, and then it's stable for 10 years, and then suddenly this lesion starts to grow, and then after 10 years this melanoma is just 0.4 millimeter. In my view, I said to the colleague, the key point is that we need a second histopathologic opinion, because I strongly think that before doing a diagnosis of a melanoma in an 11-year-old girl, we needed at least a couple of pathologists saying the same thing. Yeah? And you know what the pathologist replied? No, I'm sorry. Only the mother can ask for a second opinion. I don't leave the slides leaving my laboratory. So we didn't get the second opinion. Fortunately, the mother decided not to suit me and my colleague. But definitely, this is a very scary case.
This is the end of the story.
This is the end of the story. Yeah.
Oh, I wanted a happy end.
No, there is no happy end here.
Yeah.
This is the end of the story. The end of the story is that we have to try to find a learning point here, a lesson. What is the lesson? First, with children, it's always a disaster. Second, I don't trust the pathologist blinded. Third, before giving a diagnosis of a melanoma in a child, in a prepubertal child, really it's ethical for the pathologist asking for a second independent opinion. Because of course, if you ask your colleague sitting at the next chair, this is not independent. You know what I mean? You need an independent reevaluation. Okay? It could be that this is a melanoma, but this is the most strange melanoma in my entire career. Melanoma which is most nearly congenital. I never saw congenital melanoma.
Yeah.
So
all the lesions that I have seen in my life, like this one, are congenital anyway.
exactly.
All. So maybe this is the first melanoma, or maybe not.
Or maybe not.
Or maybe not.
So what is the lesson we learned from this case? Let's go to an island and let's enjoy life.
No, Geppi, I don't accept that we finish with this case. I will show.
No. You have to finish. Yeah. You have to
I will
finish.
show another one. Of course, I know that you know it, and many others know it probably. But anyhow, it's nice, and this is really a mistake. So, real story: patient coming in the hospital, getting in the room, being from the beginning aggressive, saying, "Guys, this is the third time I'm coming here to you. And finally, you have to help me. Finally, you have to give me a solution." And I say, okay, relax. Which is the problem? The problem is that I have this thing on my back, you know, this nodule on my back. And this is very annoying for me. This is itchy. And the previous 2 times you told me that this is nothing. And you didn't give me even a cream for this. And I said, okay, relax, let us take a look. And then we take a look, and then I understand the story, and I say, okay, now I understand. We were not wrong. This is nothing. You don't need to apply any cream. This is a dermatofibroma. It's completely benign. Don't worry at all about it. Sometimes it's itchy. Well, we cannot do anything about it. Come on, don't worry. Forget about it. And then I invite the students to learn what is a dermatofibroma. And how do you learn what is a dermatofibroma, Geppi? How do you learn?
You touch it.
Touching. You have to touch, you have to palpate. So I invite the students to palpate, 20 students palpating this dermatofibroma, okay? And then I said, okay, now if you want, take also a look with your dermatoscope, because most probably you will find the white patch in the center and the network at the periphery. And then we apply our dermatoscope. And now, please remember that a few seconds ago, I invited 20 people to touch this lesion. So, which is the mistake? Of course, this is scabies. If somebody did not get it, this is scabies with a brown triangle and with the barrel. So, which is the mistake? The mistake is that before touching, we take a look without the dermatoscope. That's the mistake in this case. Okay, so let's stop with cases. I don't know if we want to answer any questions that came up.
So many. There are so many.
Last case, Geppi, do you think that it could be a congenital nevus? Okay, but then a melanoma developing on a congenital nevus? This could happen.
Of course.
This could be the case.
Yes, but this was not the case in the previous girl, because this was a de novo melanoma. There was no signs of congenital nevus associated.
Yeah. Yeah. And also acral sites, especially in the males, even more, as I said at the beginning, melanoma developing within a pre-existing nevus is very, very rare. Then what else? Peripheral globules. Yeah, okay, guys, peripheral globules is a little bit a joke. Of course, when we see globules in an individual in an age which is very advanced, it's a little bit suspicious. But overall, I think that we have exaggerated a little bit with the story of peripheral globules. We should be a little bit more relaxed. Almost all the lesions which are symmetric and they only have a rim of peripheral globules, almost all of them will be just growing nevi.
Yeah. There is another one about when the lesion is highly suspicious clinically and endoscopically, should I do confirmatory incisional biopsy or wide excision from the start? I would not do neither the two. I would do the excisional biopsy. Excisional biopsy first, and then if it's confirmed it's a melanoma, then you do the wide excision according to the thickness of the melanoma.
Diagnosis in the last case, if you mean the case that I showed in the end, the diagnosis was scabies. What is the maximal time in which you need to re-excise a melanoma in situ for safety? So when should you re-excise melanoma?
When should we do the wide excision of a melanoma?
Yes.
Always.
Yes, when? In terms of timing.
In terms of timing. There are no clear-cut time points. Basically, you do it as fast as possible. But even if you do it 3 months later, it's okay. I mean, you know, there is no guidelines on this particular regard.
Mm-hmm. So the timing is not.
No, you do it as soon as possible, but definitely if you cannot do it, I mean, the patient is not showing, or the patient comes back and saying, okay, I went somewhere and I got a melanoma removed. When it was 6 months ago, should I do the wide excision? Why not? You know what I mean? Of course, I wouldn't do it 10 years later. Let's say so.
Yeah, because the wide excision is done mainly in order to prevent the local recurrence of the tumor.
Exactly.
Therefore, after 2 years, let's say, the possibility of local recurrence is
It's almost gone. Yeah.
And
Okay.
in terms of excision, the margin on melanoma on the scalp, what kind of margin do you recommend?
On the scalp. On the scalp.
It's one of the questions.
Same.
So, sorry, I didn't understand the question.
Scalp melanoma. What are the safety margins?
No difference from.
No difference. No difference at all. By the way, for lentigo maligna, we usually are more conservative recently, because we started to use imiquimod as a rule, as an adjuvant treatment after having removed lentigo maligna. This is a very important point. Lentigo maligna is by far the most frequent locally recurrent type of melanoma. Why? Because you are on the face, so it's difficult to be very wide in the excision, and also because this is very often a multifocal disease, multifocal lesion. So very often it recurs. Therefore, we don't care too much to give wide margins, but we care in doing a little bit of imiquimod after removing the lesion. 6 weeks every day. And we don't have, of course, definite data about the efficacy, but there is a good rationale in using it.
Yeah.
Okay, and there's a question about imiquimod, actually the oldest one on our list here. The use of imiquimod or 5-FU in inducing erosive pustular dermatosis of the scalp has a pathogenic role. It's not really a question, but I guess the question is that your opinion?
Thorsten, I don't hear you well and I don't see the question. Where are these questions at the beginning?
Scroll all the way up.
So if there is a pathogenetic role of imiquimod for the erosive pustular dermatosis?
If there is the question? If there is,
Yeah.
Well, there is no evidence on how imiquimod or 5-FU or photodynamic therapy can induce erosive pustular dermatosis, but the most reports of patients with erosive pustular dermatosis include history of a previous field treatment for non-melanoma skin cancer. Either imiquimod or 5-FU or ingenol mebutate in the past, or photodynamic therapy, without being able to propose a pathogenetic mechanism. Again, concerning the peripheral globules, maybe we should clarify it a little bit better. So, which is the idea? Basically, we start thinking about it. Why? Because from fellows or young colleagues working with us, examining lesions, saying that, okay, but doctor, why this one, there are a few peripheral globules, maybe we should excise it. And that's why we said with Geppi that at some point we have to stop with this monster that we created. Because in the past, we used to say that peripheral globules are okay until the age of 40, but after the age of 40, peripheral globules are suspicious. And then this is an overstatement. This was an overstatement. Why? Because peripheral globules just represent a sign of radial growth of the lesion. That's it. It's not a melanoma criterion, okay? A melanoma criterion is only when the globules are asymmetric in size or distribution. But if we have a peripheral ring of equally sized globules, then this is definitely not a melanoma criterion. So we should be more relaxed. Of course, I repeat, if you see in a very advanced stage a sign of a growing lesion, then this is strange. I agree. So we should be careful. But overall, no, we don't excise every lesion with peripheral globules after the age of 40, as was asked in the question. We can be more relaxed with this dermoscopic sign. That's the idea.
Yes, so you don't excise a growing nevus in a patient over 40? No, not on a regular basis.
Exactly.
We need more. We need more.
We need more. We need more.
Then there are some questions about retinoids, how they work, protopics, how they work, topical steroids.
Yeah, we discussed about it at the beginning. So calcineurin inhibitors do not seem to work very well. Retinoids, I repeat, it's just a matter of personal experience. There is not enough data. Retinoids, I think that they are a good idea both to control the disease and also a good idea if there is a history of field cancerization, that usually there is a history of field cancerization.
How long in nicotinico malignant? Well, in the adjuvant setting, 6 weeks, at least. We usually do 6 weeks every day. For treating a primary lentigo malignant, for example, without surgery. So, for example, a big lesion in a 95-year-old lady, there are evidences that you can do it. Then we need 12 weeks. How do you manage mistakes when it is a real mistake? I mean, leading to a decision with some bad consequences. Well, we have to admit mistakes first with ourselves and trying to get a lesson from the mistake.
Mistakes are the only way we improve.
And that's it. Basically, we don't have to be scared to make mistakes. Of course, we are trying to use some rules in order to avoid big mistakes with big consequences. And therefore, we say, for example, let's excise a nodular lesion when we don't know what it is. You know what I mean? Because one thing is to monitor the flat melanoma, one thing is to miss a pet melanoma.
So you know this very famous saying that a stupid person is the one repeating the same mistake many times. A clever person is the one learning from the mistake that she does and does not repeat it. And an intelligent person is somebody who learns from the mistakes made by others. So be intelligent and learn from our mistakes, which are many. Of course, we didn't have time to show all of our mistakes. We would need like a congress. We should organize a congress, Geppi, called
Mistakes.
3 days.
Yeah.
You want to answer something?
In total body mapping, should I photograph as many nevi as possible? No. Nowadays we photograph very few nevi because we are more and more fan of total body photograph. You know, so we do the clinical photographs of the entire skin, and then maybe 4, 5, 6, 10 nevi are photographed with the dermatoscope.
What else? I think we covered most, or not?
Yeah, I think so. I think we're good. There's many more questions, but
yeah, of course there are the questions concerning this plastic nevi. Maybe one last clarification on this issue. And these cases were not shown to tell you do wide excision of every dysplastic nevus you are going to remove. This was not the message. The message is decide case by case. Since dysplastic nevus is a strange category, you know, it's a category probably, it's not an entity, it's a category, it's a pod where all the difficult diagnoses are going inside, you know. mostly are nevi, which look a little bit peculiar, but sometimes you have a melanoma also going there, you know, in the category of dysplastic nevus. So that's why it's our responsibility to understand which one is most probably the melanoma which went into the pod of dysplastic nevus. That's why we need to judge case by case, and if we strongly feel clinically, based on the clinical information, that this could be seriously a melanoma, why not making a wide excision?
So, in other words, let me tell you what I do when I get the diagnosis of a dysplastic nevus. When I get the diagnosis of a dysplastic nevus, at the same moment I close my eyes and I say, unfortunately, I have to go on without a histopathologic diagnosis, because I consider that I don't have the answer to my question, because my question to the pathologist was, is it benign or malignant? And then I don't get an answer. And therefore, I need to proceed to decide without help from histopathology. That's the way that I understand, and not that I address the problem of dysplastic nevi. And of course, I'm trying to discuss with the pathologist, but some pathologists are so much, fan of the concept of intermediate lesions that it doesn't make sense to try to change their mind.
Yeah. And the degree of dysplasia from a pathologist, does it influence you?
The degree of dysplasia of pathologists, in my opinion, just expresses the degree of their uncertainty in diagnosis. This is the degree of dysplasia. How much unsure they are. I mean, if they mainly think that it's a nevus, but they are not sure, or if they are very much scared that this is a melanoma, but they don't want to sign it as a melanoma. That's how I understand it. So,
yeah.
Okay. Should we wrap it up?
Beautiful.
I think.
Ragazzi, did you like Emilio? Of course. I mean, my God, he's so handsome. Okay, but I must say, yesterday I made a clear-cut declaration. The declaration was that Torsten is more handsome than Emilio.
I protested against it. I mean, I said, you say so just because he has hair and I don't.
I'm working on losing my hair or moving my hair some other place on my body.
Torsten is a model. We cannot compete with Torsten.
Yeah. But this talk first mistakes. So anyway, this was fun. This was so thank you so much. You guys are great. I hope this was educational for everyone. I guess this is I hope I didn't underpromise. These are some of the best, the two best speakers and best teachers in dermoscopy. And I think we do need to do what we can to learn from our mistakes. And today was all about learning from the mistakes of some of the best in your field. So I hope you got something out of it. So thanks for attending. Thanks for making the time. And thanks, Geppi, Aimilios, definitely for being here and sharing your knowledge and wisdom. And we will be back here next Friday for episode 9. We will have John Paoli of Sweden here with us. So you'll get an email tomorrow with the link to the recording of today's episode. And you'll also have a chance to register for next week's episode. And as always, after you leave today, you'll have a chance to leave some feedback. So think about what we can do better, what you liked. Maybe you have some ideas for future episodes. Just put it all in there in the comment section. And for Geppi and Emilio and the entire 3Gen team, I thank you for being here. Depending on where you are, have a great day, a great evening, a great afternoon, and definitely have a great weekend. So thank you again. And
Bye. Bye.
bye.